Hi, everyone. My name is Varda. I am an internal medicine first-year resident, and today we'll be talking about heart transplant rejection, in particular, the approach we take when a patient presents with concern for rejection.
Hi, and I'm Dr. Jennifer Cook. I am one of the attendings on the CVICU B service, and I was so excited when Dr. Arshad came to me and said that this is something that would be helpful for residents and fellows rotating on the B team, and that it would be of assistance when evaluating patients being readmitted after heart transplant. So here we go.
Absolutely. So, Okay, so the first thing that we wanted to talk about was how in patients who after a transplant, they undergo surveillance very regularly, which involves routine biopsies and coronary angiograms. These biopsies are used to assess for either cellular antibody-mediated rejection, which we'll get into. But basically, for the first 4 weeks, they're done every week. For the next 6 weeks, it's every 2 weeks, then every month for the next 3 to 4 months. And then to the end of the first year, then it's every 3 months. Beyond the first year, these biopsies are done every year. And then with coronary angiograms, which are done to rule out coronary allograft vasculopathy, in patients with normal kidney functions, these are done annually for the first 5 years. And then beyond that, it depends on the risk status that the patient has for graft vasculopathy.
One thing that's really important about this is that we know that if we detect cellular rejection or antibody-mediated rejection before there's graft dysfunction, that there can be improvement and stabilization of the graft. And so that is the reason for the frequent antibody-mediated rejection and cellular rejection biopsies that we do after transplant, is to try to catch that rejection before it's clinically significant.
Right, which is very important for these patients. Now, when we talk about heart transplant dysfunction, it can either be primary or secondary. And this is just a global big picture thing, which we'll get into the details of. But secondary graft dysfunction can either be cellular rejection or antibody-mediated rejection. And this is the bulk of what we see on the CVICU B team. And then the last thing can be graft vasculopathy, which we will talk about as well. So, primary graft dysfunction basically is the presence of ventricular dysfunction, which is immediately post-transplant, and it can either be hyperacute rejection, or in the absence of rejection from the recipient, it can be pre-existing donor heart disease or reperfusion injury, which happens immediately post-transplant, or graft injury during organ retrieval and implantation. We don't see a bunch of that on our team as residents, particularly.
I was just getting ready to say that. I was like, I hope that nobody who watches this ever sees primary graft dysfunction, because it really is tragic when it develops. And, immediately post-transplant, we hope the patient comes out of the OR on, maybe one pressor and some afterload reduction. But severe graft failure post-transplant sometimes can lead to needing a balloon pump or even ECMO post-transplant. And so this is really a feared outcome of heart transplant.
Right. And then secondary graft dysfunction. So before we kind of talk about cellular and antibody-mediated rejection, a throwback to times we're all not super fond of, but basically B and T cell activation, which is our body's immune response, a T cell activation in which dendritic cells, cardiac dendritic cells, antigens, which can be MHC transplant-derived antigens or transplant proteins, which are presented by the dendritic cells to T cells, which are then via a variety of different basically signals are activated to then become cytotoxic T cells, which mediate this damage, which then leads to cytotoxic damage to cardiac myocytes, or it can be B cell activation, in which case these activated T helper cells, which were activated here, are then basically release cytokines, which release immature B cells to form mature B cells and then produce antibodies, which can mediate damage. And this then leads us to acute cellular rejection, which is cytotoxic T cell mediated. So the diagnosis of this is made by histological identification of leukocytes which infiltrate cardiac myocytes. And then grading is done after a person undergoes biopsy. So grade 0, in which there's no rejection detected. Grade 1, which is mild, in which there's interstitial or perivascular infiltrates with up to one focus of myocyte damage. Grade 2R, which is moderate, in which there are 2 or more foci of infiltrates with associated myocyte damage. And then grade 3R, which is severe, in which there's diffuse infiltration of lymphocytes with multiple areas of damage, as we see here.
I think that this is wonderful to be able to show these histologic, pictures, because I don't know if we get a chance to see the histology except for medical school, and then fast forward to residency and our fellowship when we're taking care of these post-transplant patients. And so just for a second to orient ourselves to these beautiful images that you provided for us, the top you see the normal striated muscle. And one of the things that you see about the myocytes is that they're not nucleated. And so if we see a nucleated cell in there, it's usually an endothelial cell or a lymphocyte. Compare that to the image on the bottom where you see multiple nucleated cells. And so this is infiltrates of leukocytes in the cardiac myocyte. The other thing that you notice is that the architecture, the nice striated architecture of the myocardium is no longer there. And you can even get an opportunity to see where the lymphocyte is chewing on, I like to say chewing, but it looks like it's chewing on the myocyte and causing that damage. And so this example on the bottom figure is an example of severe 3R rejection with diffuse multifocal myocyte damage.
Yeah, and you're absolutely right. I don't think we see much of that. So it's very interesting to actually see it laid out.
Mm-hmm.
So that's cellular rejection. And then the next one we have is antibody-mediated rejection, which is mediated by the B cells. So antibody-mediated rejection, there's 4 things that are present. One would be the clinical evidence of graft dysfunction. We look at histological evidence of acute capillary injury, which can be endothelial changes or macrophages that are present there. And then another aspect in antibody-mediated rejection is immunopathological evidence of injury, which is immunofluorescence staining or immunoperoxidases. And then the 4th thing is serological evidence of anti-HLA or anti-donor antibodies, which are used to detect antibody-mediated rejection.
So I can speak to this a little bit. So our histologic evidence of acute capillary injury will actually be seen on the image on the previous slide. And so that's our histology, and that's our formalin sample. And what we see there is swelling of the endothelium. And so we see those endothelial cells because they're usually cross section on the biopsy specimen, and we can see endothelial swelling or macrophages in the endothelium. Now, this is our immunoimages. And so our immunoimages are actually looking for complement deposition. So remember back, the reason why our first slide was so important is that we got to remember the way that it works when there are antibodies that are binding to cells and then opsonization and then activation of the complement cascade. So what we're doing is we're looking for activation of the complement cascade in the cardiac myocardium. And so we do that by looking for complement byproducts C4D and C3D. And so in this image here, we see C4D and C3D atop by the histological appearance by peroxidase staining, and then on the bottom, the immunofluorescence staining. And so immunofluorescence basically is, when they look under the fluoroscopic microscope with tagged antibodies to the C4D and C3D. And one thing we can appreciate here is that the lighting up of the C3D and C4D seem to be at like donut shaped. And this is how it is described when there's endothelial staining. And the final thing that's worth mentioning, and I don't think we have a next slide on this, so I'm going to talk about this now. Is that all right, Berta?
Yeah.
Is the serological evidence. So just to explain the serological evidence, every single person has HLA typing. And so the HLA are the surface receptors on our cells that are present at the time of our embryological development. And remember, our spleen is able to detect any lymphocytes that detect self and then destroy those cells during our embryologic development. So we all have HLAs, but we shouldn't have any antibodies to HLAs. Sometimes, though, people can develop antibodies to HLAs, like for instance, if they get a blood transfusion, or this happens really frequently in women who have children, then are exposed to the baby's HLA and then develop antibodies to that HLA. And so we all have HLA typing. We should not have HLA antibodies. So we look for HLA antibodies before transplant. And if we find it, we say their patient is pre-sensitized. And of course, if you are pre-sensitized for an HLA antibody, we would not want to give you a heart with that HLA antigen. So that's the way we look at HLAs prior to transplant. But post-transplant, we save the donor HLA profile. And so basically what that looks like is like A6, B12, et cetera, of the donor. And then we look for any HLA antibodies in the recipients. And if we find HLA antibodies in the recipients, we look back to see what the donor's HLA antigens were to see if it's a match. And so if our recipients are making antibody to their donor HLA, we call those donor-specific antibodies. And we can measure those circulating donor-specific antibodies by sending blood samples for HLA DSA.
That's very helpful. And then basically based on histological and immunopathological evidence, antibody-mediated rejection can then be graded, which is grade 0, where there's neither histological or immunopathological evidence. There's grade 1, in which it can either be histopathological alone or immunopathological evidence. Grade 2, in which both histological and immunopathological staining is seen, and then grade 3, which is severe, in which on histology we'll see interstitial hemorrhage, capillary fragmentation, and edema. So that helps us then guide treatment and how these patients are basically treated.
Can I give you a little insider tip as well? Is that in our system at University of Cincinnati, the histologic biopsy is read by the UC lab, and the immunologic biopsy is read at Children's. And so whenever we do a heart biopsy, we'll get the pathologic result, and then the immunologic result will come as an addendum, usually a day or two later. And so if you look at a biopsy that was done a year ago, you'll see the whole report there. But if you biopsied a patient yesterday, you might just get the histopathologic information with the immunologic information coming later. So that's your insider tip.
That's a light bulb moment for me, because I remember that the patient that I had, I saw the pathology report and I thought that, well, this is done and dusted, no rejection. And then the following day, everyone else was kind of talking about the immune staining, and I didn't know to go back and check. So that is a very helpful tip. Now, with this background in mind, how to approach a patient that comes in with concern for antibody or cellular rejection. There are important elements in the patient's history to know about, including the signs and symptoms, which can really be anything and everything under the sun, from any kind of pain, arrhythmias, any dyspnea on exertion, really any symptom that they experience. Their history of cardiac transplant, what kind of immunosuppressive therapy they're on. Most commonly, patients are going to be on Tacro. Compliance to therapy is very important, because if for any reason they haven't taken their medication, that puts them at a higher risk for rejection. Any recent illness, a history of rejection if they've had any in the past, what their most recent coronary angiogram showed, and what their most recent surveillance biopsy showed. These are kind of the important things to know about when a patient comes in initially.
And I can give you a tip too, is that whenever you are presenting a patient who's had a heart transplant, you should assume that they have normal graft function. And so any abnormalities in the heart by echo or by coronary angiogram in the past should go into the HPI as far as describing the course post-transplant.
And then for workup, as Dr. Cook mentioned, to assess for any kind of graft dysfunction, transthoracic echocardiograms, a right ventricular biopsy, which is then sent for histological and immunological staining, donor-specific antibodies, which we discussed, and then depending on how the patient presents and how high their risk is, a coronary angiogram can be considered as well. This is kind of the workup that these patients undergo to to rule out biopsy rejection.
Rita, have you ever had a chance to see a patient post-transplant that had coronary abnormalities?
I actually haven't.
Yeah, one of the things that's so special about them that's important that we know is that after a heart transplant, the heart is denervated. So they cut the nerves to the heart. And so our patients post-transplant could have angina and even have an ST elevation myocardial infarction with no anginal symptoms at all. And so EKG can be very important in the workup of these patients, and you can have silent ischemia post-heart transplant.
Right. Which would be a very important component in these patients.
Mm-hmm.
And then management is going to depend on the grading that we see. So in acute cellular rejection, if it's grade 1R without any kind of hemodynamic compromise, these are patients that we'll usually monitor and they won't undergo any further treatment. Grade 1R with hemodynamic compromise or grade 2R without compromise, those are patients that will generally get pulse dose steroids either orally or intravenously. Grade 2R with hemodynamic compromise or grade 3R, those are kind of patients that are treated the same way with anti-thymocyte globulin or OKT3 antibodies. And then in these patients, their home medication, their cyclosporin and mycophenolate, if they're taking those at home, they're continued at the doses that they were taking before. And for antibody-mediated rejection, if a patient is symptomatic, they will be treated with, can be treated with corticosteroids, with anti-thymocyte globulin, or OKD3 antibodies. And then rituximab and plasmapheresis is something that can help these patients because they're circulating antibodies, which are causing the damage.
Mm-hmm. And so with antibody-mediated rejection, because they're circulating antibodies, we need to clean the blood. So we'll do pheresis and then give thymoglobulin to reduce the production of antibodies. Another treatment that we do for AMR is IV IgG, and that's really to supplement the patient for immunoglobulin once we remove all the immunoglobulins. Additional thing I'll mention on this slide is that sometimes you'll see the transplant cardiologist giving steroids empirically because of if a suspicion of rejection is high, even before we get a biopsy. And so it won't be uncommon for you to see a patient to get a gram of solumedrol empirically because of suspected rejection. And this is something that we would do if we brought a patient in that we thought might have rejection who has a decrement of the ejection fraction by echo. Go ahead and give them solumedrol and get them biopsied as soon as possible.
That actually is a perfect segue into our next slide where just a global picture where a patient who comes in and on history, physical exam, where there's signs concerning for rejection, depending on the degree of clinical suspicion, is basically how those patients undergo evaluation. So degree of clinical suspicion is low, they'll undergo an echo. And if there's any degree of dysfunction on that, they will undergo a right heart cath with biopsy. And then depending on the grade and type of rejection, they will then undergo treatment. But as Dr. Cook just mentioned, if the degree of clinical suspicion is high or moderate, then in those patients, they can sometimes get treatment before any of the workup is done, because that can take some time, but we have to stay on top of treatment to prevent damage before it gets too bad for these patients. And then the exception to this workup is, of course, patients who are diagnosed with rejection just on their surveillance biopsy. And then the next thing that we'll talk about is cardiac allograft vasculopathy, which is basically an accelerated form of obstructive disease of the coronary arteries. Which tends to be a diffuse process as opposed to the traditional coronary artery disease where it's more focal. And angiography is usually our go-to to detect vasculopathy, but it does lack sensitivity in these patients, and intravascular ultrasound is what's most sensitive. Treatment options in these patients are very limited, and why they're limited is because there's usually not a focal lesion to treat in these patients, and prevention because of this is of utmost importance. And so statin therapy, which all of these patients will be on, and then other things that can be considered are sirolimus, everolimus. And from what I understand, sometimes if these patients have an identifiable lesion, they can get drug-eluting stents with these drugs, sirolimus and everolimus, that can help these patients, basically.
Absolutely, that's correct. So there is evidence that using statin therapy is prophylaxis for allograft vasculopathy. So you'll see all of our patients that are on a statin, even if they don't have pre-transplant hyperlipidemia. And then finally, we use sirolimus or everolimus orally in order to reduce the progression of allograft vasculopathy once it's detected on our surveillance angiogram. And usually it's the diagnosis is made by IVUS. And I'd like to speak to as well the image here of that's shown on the slide. You can see the nice natural appearance of the coronary arteries in A, but in B, you see this diffuse tapering of coronary arteries. It almost looks like a diabetic's heart. Kind of gives you a feel for this, diffuse process. And I like to think of allograft vasculopathy as being kind of a chronic rejection of the heart, where there is narrowing of those coronary arteries over time.
Yeah, and I didn't understand the full impact of how bad it can really be until I started kind of studying more in detail about this, because these patients, their endpoint would really be another transplant if they're candidates for that at that point.
Mm-hmm.
So that kind of sums up our approach to patients. And then one thing that we wanted to discuss in addition are how these transplanted hearts are different from normal hearts that patients have. And as Dr. Cook mentioned earlier, transplanted hearts are denervated. They don't have any sympathetic or parasympathetic supply, and they also don't have any visceral afferent fibers, which is why they can't feel any pain. Their resting heart rate is usually going to be higher, so 90 to 100 beats per minute. I remember a patient of mine had their heart rate was in the 110s and 100s, and I on rounds brought up that, oh, they're tachycardic, and that's when Dr. Cook actually pointed out that transplanted patients, that's what we would expect in these patients, versus a normal heart rate where the average beat is 60 to 70 per minute. And then because they lack afferent innervation, this means that they will not experience any pain. So if there's any underlying ischemia, we might not be alluded to it by the traditional signs and symptoms. And then there are also some pharmacological differences because of these differences in innervation. Atropine is not a medication that can be used to treat bradyarrhythmia in these patients. Digoxin is also something that should not be used to treat arrhythmias, especially atrial arrhythmias, again, because of denervation. And then beta blockers in these patients, when possible, should be avoided in the first 6 months because they decrease the exercise tolerance of these patients. They rely mostly on circulating catecholamines to mount that response when they exercise. And so beta blockers can decrease their exercise tolerance further. And those are the pharmacological and physiological differences that these transplanted hearts will have compared to a normal heart in a patient. And that brings us to the end of our talk.
Yeah, I think that was extremely helpful. And so basically what we were able to do is to bring to you what would be about 3 different sessions of teaching on the wards to make sure that everybody gets a chance to hear about transplant rejection before you're challenged with it in the middle of the night, admitting a patient for us. So thank you so much for your attention, and thank you, Dr. Arshad, for putting all this together. Well done.
Thank you.